Hi, everybody. Thank you for coming to the 2016 Resident Research Day for Orthopedic Physical Therapy. I know there's some people watching online, and it is being recorded as well. So again, thank you very much. And as people come in, just have a seat and relax and enjoy. Today we have two of our residents who are graduating in December, two of our senior residents. The first is Dr. Akriti Sharma. She is a graduate of Rutgers University, and her research has been on cost of care regarding low back pain throughout the course of 18 months or so after care starts. So without further ado, I'll turn it over to Dr. Sharma.
Good afternoon, everyone. I want to thank everyone for attending my research presentation this afternoon that I've been working on this whole year. So I'll be discussing the cost of care associated with low back pain when receiving physical therapy versus imaging first. And it turned out to be a pilot study. And we'll go to the next slide. So there's no financial disclosures of myself related to this study. So just by a raise of hands, how many of you have ever experienced low back pain at any point of your life? All right, so I want to say that looked like it was pretty much majority of the audience put their hands up. So at any given time, 20 to 30% of the population experiences low back pain, and 80% of the population reports that they have had symptoms of low back pain at some point of their time. Allowing symptoms to go unrecognized can lead to chronic low back pain, and this is really significant because chronic low back pain is the most prevalent musculoskeletal impairment for people under the age of 65. It's also, there's research that's out there that's showing it's the leading cause of disability. So I really like this graph. It's from 2005 CDC. It shows that right over here that low back pain is the second most leading cause of disability among United States adults. There were 7.6 million people reporting back or spinal problems out of 47.5 million Americans who are reporting disability. So it shows that it's a major problem, as this is depicted in the graph, and it can have serious detrimental effects on people and can lead people to go on disability. So this graph shows the trend of physician visits due to low back pain from 1998 to 2010. It showed that in 1998 there were 32 million visits, and in 2010 there were more than 50 million. So it's showing a very rapid increase, a rapid increase in the rise of the number of population that's having issues with their back and going for primary care visits. So this is becoming an economic burden. There's $100 to $200 billion that are spent annually on treating people for low back pain. Frequency of low back pain has shown to increase with age, and it commonly leads to activity restriction, time lost at work, and disability. People continue to work through low back pain, but recognition of the first signs and symptoms are very crucial. So this has also led to an increase in imaging, spinal injections, surgical procedures, implantable devices, and medications. So a little background I'm talking about non-specific low back pain. The medical guidelines recommend minimal imaging. Even though these are the medical guidelines, imaging is still on a rise. In the absence of red flags, pathology is shown to be age-related and typically benign. These procedures not only raise healthcare costs, but they have also failed to generate improvements in patient outcomes. And there have been studies that have done on the West Coast where they compared physical therapy first versus advanced imaging. They showed that people who went to physical therapy first had lower healthcare utilization and costs. So the purpose of the study that I conducted was to compare the healthcare costs for non-specific low back pain receiving physical therapy versus imaging first. And this was done over an 18-month period. So my methodology included, it was a retrospective claims data analysis, and it was claims data from St. Luke's University Health Network that was extracted from the time frame of October 1st, 2012 to October 1st, 2015. Patients with a new primary care low back pain consultation were identified and characterized as non-specific or specific based upon low back pain related ICD-9 codes. So the inclusion criteria were non-specific ICD-9 codes for low back pain. And the exclusion criteria were care relating for low back pain for at least 6 months, age less than 18 years old, and especially we excluded people that had red flag symptoms. These included myotomal, dermatomal weakness, absent or hyperreflexes, clonus, or other indications that indicated upper motor neuron or lower motor neuron lesions. So I'm not going to read all of the exclusion criteria, but it's all listed here. Kidney stones, like referred pain, pregnancy, any type of specific low back pain like ankylosing spondylitis, those were all excluded in our analysis. The covariates were controlled for. These included age, gender, number of comorbid diagnosis, diabetes, hypertension, neck pain, number of days from index visit to PT, and number of days from index visit to receiving imaging. So there were over 100,000 claims were found for approximately 45,000 patients, and so we had a huge amount of data. However, since the analysis that we wanted to conduct required aggregate claims data for each patient, the analytics and business intelligence department, it did not have the ability to compile all of this data for us to use. So a lot of it we had to do by hand ourselves. This is why we had a small sample size of 467 patients. We were looking at specifically patients that received imaging versus physical therapy for the initial pathway. So after we looked at this, there were only 7% of the 476 that were included in our analysis, which was an N of 34. So the 7% that were included, I just want to reiterate, these were patients who had non-specific low back pain because we were excluding red flag symptoms and all of that. Other studies have shown that there should be at least a sample size of 3,000. That's what's been shown in the past to really lead to significant differences to show an effect. So in comparison, this is why this turned into a pilot study. So the patients that received physical therapy first were only 5% in the St. Luke's Health Network. And this is actually lower than the patients receiving physical therapy first in different parts of the region, including the West Coast. That's what previous research has shown, that at least 7% are receiving physical therapy first versus the 5%. So we actually fell below what other regions in the country are doing. Again, our sample size was small because of the complications that we faced when retrieving the claims data from the business and analytics department. Instead of receiving the total cost, which is what we wanted to look at, we received costs for every encounter. A lot of the data included hospital procedure codes. So therefore, multiple revisions needed to be made with coding. This included physical therapy, imaging, and office visits. And actually, so since they didn't have the resources, what the business and analytics office had to do was outsource out, and that to consultants to do this for us, and that was actually an expense of $20,000. So this is comparing the baseline characteristics between patients receiving physical therapy versus advanced imaging to make sure that there were no between-group differences when accounting for covariates. For age, we use the t-test. To compare gender, diagnosis, and hypertension, we use the Mann-Whitney-U. And we excluded diabetes because these people were removed from the analysis because the sample size was very small. So they were just excluded. The average number, this chart here is looking at the average number for days to start physical therapy versus the days to get imaging. Well, not to actually get imaging, but to go for imaging. So it showed that the average number of days to physical therapy was 63, and the average time to go for MRI was 23 days. So here it's showing that it took longer for patients to see a physical therapist and a shorter amount of time to go for imaging. And these were the results of the total costs. Because the sample size was small and there was high variance, we used medium range for total cost of receiving physical therapy first versus imaging. So it was around $8,622 for imaging, and for physical therapy it was around $5,470. And 71% of the people who received MRI first also received injections. And these were the median ranges. So this is the difference in the cost between the two groups, $3,152.90. In addition, the average number of days to MRI, which was 23, and to physical therapy, which was 63, also demonstrates that MRI is being overutilized and is costing more. This is not following the recommended medical guidelines, thus affecting overall costs. So I just want to make it a point, physical therapy was only utilized 5% of the sample size, which is actually less than other studies, which I've mentioned before, which they show to utilize physical therapy at least 7%. All right, so what's the big deal of all this? So studies have shown that chronic low back pain leads to poorer outcomes. These results are really important for providers in all primary care because it really matters where the patient goes after their initial primary care visit in terms of costs and overall patient management, especially when it comes to non-specific low back pain. Also, studies have shown that if patients receive sooner medical attention when they have initial symptoms of non-specific low back pain, they have a lower risk of developing chronic low back pain, which is harder to manage, harder to treat. Just by a show of hands, like how much success do you guys have with chronic low back pain patients? It's really challenging to treat them. Right. I really like this graph. It's from the Virginia Mason Medical Center from 2005. They developed it, Path to Recovery. The older approach was when a patient had symptoms of any sort, they would go see their primary care first, then they might see a specialist. The specialist may order an MRI, then they would go back to the specialist to discuss the findings of the MRI, and then they would go see physical therapy. Now, this new approach is showing of someone having low back pain and going directly to physical therapy, and through our education, we know when it's appropriate to refer people out who have red flag symptoms. So this had just shown to decrease overall costs when the patient immediately meets with the doctor and therapist, or even with direct access directly to PT. So, conclusions, we had a large sample size, but we need to be able to use the sample size. So in the future, we're going to continue to perform ongoing research to figure out how to improve our system. We had a large sample size of over 45,000 patients. However, due to a lack of resources through the analytics and business intelligence department, we're not able to utilize and analyze it all. The first step in figuring how to improve our system is to be able to analyze the data correctly in order to have good data to demonstrate where the problems lie and have plans to fix the problems. So the limitations of my study. Small sample size due to the time constraints and inability to analyze other pathways taken by patients. We're not able to see if these patients received care outside of the St. Luke's network facilities, including physicians participating in different healthcare networks, specialists, and chiropractic care. Pain medication usage was not able to be retrieved through the retrospective chart review, and the impact of medications on CAST analysis, that's something that we weren't able to look at. Functional outcomes of patient pathways was also not able to be identified, and that's something really good to do in future prospective studies, because with our studies we're showing, okay, physical therapy shows people who go straight there with non-specific low back pain have lower costs. Now, are these people having better functional outcomes than patients who go for MRI injections or surgery? That would be things to, I think, really interesting to look at in the future to really see how it's affecting their function. So also with the research, instead of receiving total costs, we received cost of every encounter, a lot of the data included hospital procedure codes, and multiple revisions need to be made with the coding. So it was a lot of work on our end, and thus we had a small sample size. And those are my references. Does anyone have any questions?
So just to clarify, so those costs were downstream costs or just the cost of physical therapy? Therapy or MRI, so the $8,000 or the $5,000, or was that all costs associated with low back pain over 18 months?
Total cost of imaging when patients received imaging first versus total cost when patients received physical therapy first. Any other questions?
I apologize. I think you might have said this, but I might have just missed it. When you look at the days to the service, whether it was MRI or physical therapy, was it the days until the service was actually provided, or the days from when there was an order placed in the chart?
Can you repeat that?
Yeah, sure. So when you talk about the days, the 23 days for the MRI and the physical therapy was the 63 days.
Mm-hmm.
Was that days until the actual evaluation of physical therapy and actual MRI was performed, or was it from the time when there was their first visit to when there was an order placed in the chart before this?
The first one. Yeah, that's when it was actually performed. Yeah. Mm-hmm. Okay, thank you. Well, first off, we want to continue this study, but we want to be able to have data that we could use. So maybe having more resources in the business and analytics department. So this.
Why couldn't they get the information from the data analysis? All those patients that have down further.
What's that? Say that again.
Why couldn't they break the data down further? All the analytics that we have here in our system.
They actually had a outsource to consultants to break it down and analyze it. And Steve probably has more input on that because he was heavily involved in that portion as well.
That's for another time.
All right, thank you.
To give a brief response, is we were told they do not have the manpower to do so, and so they had to outsource. The analysis that we asked for apparently was too complicated, which is sad because this is something that is extremely important and crucial, but we were told that we do not have the manpower to do so. So they are actually using this study as an example to make a claim that they need more manpower. So something very good that this came out of this. But we are continuing to analyze the other 44,000 patients. It's just we have to manually recode everything. So it's a lot of time. All right. So, thank you, Dr. Sharma. Next, we have Dr. Arthur, who graduated from Andrews University in Michigan. And he is also a senior resident who, and his research was on the retention and short-term effects of preoperative pain neuroscience education for shoulder disorders.
All right, hello everybody. Thank you for coming out today. So my study is on the retention and short-term effects of preoperative pain neuroscience education for shoulder disorders in the format of a case series. So just to give a background about this, pain is a significant issue that we see following many orthopedic surgeries and procedures. And in Mosley's study, he found that patients have poor knowledge of how pain actually works. And how he did this study is he took about 300 patients with chronic pain, and he had them do the neurophysiology pain questionnaire, which rates how they're able to understand pain and how it works. He also took a portion of those people and had them go into a 3-hour video presentation of how pain physiology works. And health professionals were asked the question about how these patients that had the 3-hour session, if they were able to understand more about pain. And these health professionals, it was shown that they underestimated patients' ability to understand pain. And of these health professionals included physical therapists, physicians, occupational therapists, as well as psychologists. And so this, as Mosley put it, was just a big barrier to actually teaching patients about pain and how to help their pain on their own. Just because if a teacher doesn't believe in a student, how's a student supposed to learn? When given the pain neuroscience education, patients can improve knowledge of pain both in the short term and in the long term, going up to about 3 months. All right, so what is pain neuroscience education? How many of you know or have heard of this? Just a raise of hands. Okay, good. So there's some that haven't, so hopefully we'll be able to learn more things. So what it does is it describes the biology and physiology of the nervous system and the brain's processing of pain and nociceptive input. So with the chronic pain population, it de-emphasizes the tissue injury and tries to reconceptualize a patient's pain experience. So if we put this into an example, we have a patient that hurts his foot. So his nerves are sending a danger message to the brain to let the brain know that there's a danger out there. And at that point, that's a normal response. And typically we'll see that that's an increase in nerve sensitivity and nerve firing. And normally that should decrease after that pain signal goes away. However, that pain signal, that nerve sensitivity can actually stay elevated for a prolonged period of time. And if that is the case, then sometimes that can lead into chronic pain. And so for fixing the chronic pain, what it's shown in the literature is that reconceptualizing a patient's pain experience through education of peripheral neuropathic pain and central sensitization, that can help in decreasing that nerve sensitivity. So peripheral neuropathic pain is that signal going up from the foot all the way down, all the way up to the brain. So that danger signal that's being sent. And the brain has a very key point in this of reconceptualizing pain because it interprets that signal to give it meaning, whether it should be something that is painful or something that is not painful. So if the brain is unable to appropriately interpret that signal, that's when you get this central sensitization. So in summary, the central sensitization can cause pain. And in summary, perception is a big role in reconceptualizing a patient's pain. So now let's talk about what effect we've seen in the literature of pain neuroscience education. Well, in one case series done by Adrian Lau in 2011, he looked at 10 preoperative patients that were undergoing lumbar surgery, and he found that they had immediate changes in pain catastrophizing, and that was carried up until 6 months afterwards as well. They also showed that it improved their range of motion, lumbar range of motion immediately. In a systematic review done with patients that had chronic musculoskeletal pain, he found in 2011 that it had a positive effect on pain, disability, catastrophizing, as well as physical performance. And in another systematic review of total joint replacements, it improved their preoperative anxiety levels and patient knowledge and realistic expectations after the surgery for how pain would be like. And in previous studies, the lowest that they've been able to accomplish this is in 30 minutes, which is somewhat of a burden to the healthcare provider as to have to find 30 minutes in which you can try to administer this sort of education. So just a background on opioids, the main issue we're seeing is with those taking it for a longer duration. This is when more of the opioid abuse comes into play, and as they're meant to be prescribed for the short-term use, and they have been shown to be beneficial in that short-term use. However, 1 in 4 patients prescribed opioids for the first time progressed to long-term prescriptions. So that's for patients that are just in general getting opioids. From those that are elective surgical candidates, this percentage was 3.1% that continued opioid prescription in the long term. So we got a 3 to 25% range as to when patients are taking it in the long-term range. Axelson in 2005 stated that other routes of managing post-op pain are needed, as medicine has a limited effect for managing this persistent post-operative pain. So what we see in the gaps of the literature is that there is limited research for pain neuroscience education retention in the post-operative population, and that there's no research conducted for the use of pain neuroscience education in shoulder disorders or shoulder orthopedic procedures. So our hypothesis was looking into see if preoperative pain neuroscience education can be retained in patients who will undergo shoulder surgery. Secondarily, we also looked to see if this education could improve shoulder range of motion, improve shoulder function and pain using the American Shoulder and Elbow Surgeon score, as well as decrease pain catastrophizing utilizing the pain catastrophizing scale, and to decrease opioid usage post-operatively. So just to go over some of the outcome forms we used, we have the ASES, which measures functional limitations and pain of the shoulder. It uses a 100-point scale. 50 of those points go towards the pain scale, going from 0 to 10, and the other 50 points go towards ratings for ADLs. And they're the internal consistency numbers. Then we have the PCS as well. This is a 13-item 5-point Likert scale, which assesses inappropriate coping strategies and catastrophic thinking about pain and injury. So it's a total of 52 points. For the average healthy individual, they'll get about 18. And if it's 30 and above, that's when someone's to be deemed clinically relevant for pain catastrophizing. And it has 3 different domains focused on rumination, magnification, and helplessness. All right, so this is how we went about doing our study. First, we took 2 patients preoperatively and had them fill out the pain catastrophizing scale, the ASES, and check their active range of motion. And this was within 1 week of their operation to be performed. After that, we had that about 10 minutes of a pain neuroscience education session intervention that we had with the patient, and then check those measures again, the PCS, ASES, and active range of motion. Then after they had the surgery, they came back for their first post-operative visit within 6 to 9 days after the operation. Then we checked the PCS, ASES, an open-ended retention quiz, which we administered to them, and we tracked how much opioid use they had been using. So our first patient here we have is a 42-year-old male who was undergoing a left slap repair. His mechanism of injury was coming down eccentrically from a bench press, lowering it with left trunk rotation. His length of symptoms were about 3 months. And our second patient is a 75-year-old male undergoing left rotator cuff repair. His injury was more of chronic pain from repetitive use, as his length of symptoms lasted more than 5 years. So just some key things to point out here is that we have 2 distinct surgeries, and the mechanism of injury for either one is a bit different. For patient 1, we see there is more of an acute injury. For patient 2, it's more of the chronic repetitive use. So when we administered the retention quiz, the 3 questions we focused on were: how does pain work? What 3 factors increase pain, and what 3 factors decrease pain? So the patients mentioned these results. Patient 1 and 2 mentioned nerves send signals to the brain and nerves are irritated. 3 factors that increase pain are injury, focusing in on it, and movement. Things that decrease pain being physical therapy, we hope, right? Medicine, not obsessing over it, medication, and focusing on other things. Our results for the ASES, looking at the shoulder function and pain, showed good increases for both patients. The minimal detectable change was 9.4, and both of these patients were well over that mark there. Also looking at our PCS, we see 2 different results. In patient 1, he showed a decrease of the pain catastrophizing scale score, starting at 4 and then going down to 0. For patient 2, he actually showed an increase going from 6 to 9. And however, we do have to keep in mind that it would not be a clinically relevant number, since that number would be at 30 at baseline, whereas these patients were at 6 and 4 at baseline, suggesting a low likelihood of having pain catastrophizing. All right, so now looking at the opioid usage. So what we looked at is what was prescribed from the physicians, how much was taken, and what percentage reduction was taken. So for patient 1, he had a 70 to 90% reduction in opioid usage when compared to what was prescribed. In patient 2, he had a 44 to 72% reduction compared to what was prescribed. So now let's talk about all this and bring those results we just talked about into what really matters. So for our pain neuroscience education intervention that we gave, we performed it in about 10 minutes. In current literature, the lowest they were able to do it in was about 30 minutes. So this in itself provides flexibility for the healthcare provider and to add it into their treatment workflow in a more practical way. Also, to measure the pain neuroscience education retention, we use descriptive data with open-ended questions rather than using standardized neurophysiology pain questionnaire, which was used in the literature to measure the retention. And when we think about what the patients responded, both of them described how pain works as nociception, talking about pain coming from the bottom up, right, giving that danger signal. But they didn't mention central sensitization portion of the pain from the top down. So the brain's ability to perceive that signal as a pain response or something that is not of any harm. Also, comparing the first and second patient, we see a difference in perception for things that increase pain and decrease pain. Patient 1 mentioned the things that increase pain are things such as the injury itself. And patient 1 was the person that had more of the acute injury, so he's thinking more so about his injury. And things to decrease pain, he mentioned medications and physical therapy. Whereas patient 2, the one with the more chronic symptoms, he mentioned that things that increase pain is dwelling on it and thinking about focusing your attention on it. Things that decrease it are focusing on other things and medications as well. So we see a little bit of difference there. It seemed almost as that the second patient was able to understand that it's more about perception and your brain's ability rather than the injury itself. With looking at the ASES, as we mentioned before, it did show positive changes after the intervention for about 11 points for patient 1 and about 31 points for patient 2. And this was shown to be well above the minimal detectable change score there. And what we analyzed this for, so ASES is looking both at shoulder function as well as pain. And this, we would think, primarily deals with the change of pain because we were able to potentially affect the perception of the patient when they took this form. Talking about the PCS, current research shows that a decrease of PCS is immediately shown after the intervention. And with patient 1, we did show a decrease in that. However, with patient 2, it showed that there was an increase. Although both of these changes were not of minimal detectable change, which needed a change score of about 9, we only saw about change score of 3 for both patients. And like we talked about before, this was not clinically relevant for pain catastrophizing since the scores, both 4 and 6, were not above that 30 out of 52 point. Looking at the opioid use in patient 1, we saw that he had a 70 to 90% decrease in his opioid use. And patient 2 had a 44 to 72% reduction. So perhaps there could be a correlation between looking at patient 1 having a decrease in PCS and having a greater reduction in opioid use. However, this is not able to be determined by this data set because of the level of evidence of this study, but it is an observation to keep in mind. So some limitations of this study is that it was a case series, so no large sample size or control group. Therefore, with the pain neuroscience education retention, we weren't able to actually have a control to actually compare it to determine whether it's truly effective or not. And patients' views towards medicine and their outlook towards opioids, their experience with prior medications could have been a factor in why they didn't take as many opioids. Also, measuring retention without using a standardized quantitative outcome measure such as the NPQ was another limitation of our study. Future research could warrant using higher levels of evidence such as randomized controlled trials and case control studies looking at the retention of pain neuroscience education and with this NPQ outcome. Also looking to see if there is a correlation between the PCS score and opioid usage, and how we could use that in the future would be to predict if there would be any lower opioid use if a patient has a lower PCS score, or to predict who will need more pain neuroscience education for those that might be more likely to abuse opioids. This would also in turn help the medical financial burden. In conclusion, to wrap up all our findings, we found that utilizing an evidence-based pain neuroscience education session, we were able to have some retention for knowledge for patients postoperatively. This information was more so learning of the nociceptive information, and we did find some limitations in patients being able to understand the central sensitization aspects of pain. And so in further studies, perhaps we can try to put more emphasis in our education on focusing on what our perception and what our brain can do to control pain. Also looking at the ASES, we found that there were functional improvements and pain improvements of the shoulder, both immediately after the pain neuroscience education. Looking at pain catastrophizing, we saw while pain catastrophizing was not significantly changed, we do not know how much it changes normally postoperatively since we did not have a control. So this could be utilized in future research as well to be able to make better comparisons. And we did see that opioid usage was observed to decrease after pain neuroscience education when compared to the prescribed dosage used. And here are the references. And are there any questions that you have? Allison, yes.
I have two questions, but I'll answer my Allison first one first.
Sure.
You just talked about opioids. Is there an average amount of opioid use after just any surgery that you know a number of that you can compare the base of what you were seeing with your patients?
Right, that's a very good question. So one of the greatest surgeries that showed for, there we go. All right, for what surgery utilized the most opioids was like the total knee replacements. I did not actually look to see what actual numbers are prescribed, but yes, that's definitely something that we can compare in the future.
Because the thing I see a lot with opioids is depending on the person, it's just a prescription, so it's taken
Yes.
as needed, but do not exceed this. So that's kind of what I was getting at with, depending on where that is. And then my next question is,
No problem.
now you followed up with this patient's long term, I guess, since it was a case series. Do you think, no?
No, this was not long term.
Well, sorry, did you continue to treat them?
Yes.
So this is outside of the study. Did you feel that the education actually did help them overall in the rehab process as compared to somebody with a rotator or a slap repair who didn't have this education?
Right. I think it is hard to compare just because we don't have the actual data. So I'd only have to speak from, personal experience.
That's what I want. Like, what is your personal experience? What have you noticed in the clinic?
Well, I think it's really important to be able to get them. The main thing about getting a patient to change their perception is to see if there's actual learning, right, occurring. And so that can't just be tested at a one-time basis, which is why it's good to see for long-term. And that's where we'd like to take this study as well, to get it to see if there's any more long-term implications there too. Now, with that being said, if giving handouts which is what we did, also helps with the retention and actually checking with the quiz at that secondary point to be able to jog their memory to think about what types of symptoms and things that they can extrapolate from that to use practically. So I would say that I did see. Is that all right? All right. So I would mention that, yes, I think I did see, a difference clinically just with their ability to be able to, for one, to wean off the medications pretty quickly. In terms of function and things like that, I think, pretty standard, but yeah, that would be my synopsis of that. Thank you.
Quick question, the preoperative education piece.
Sure.
You said yours was about 10 minutes, give or take. The other research was about 30 minutes. Could that be education that could be given to a patient by a nurse as well as a therapist? Or is it very specific terminology that only we would really understand? And I don't mean that in a disparaging way, but I'm just thinking instantly, the joint classes or the pre-admission testing that we have here for joints, it's a great opportunity to capture people. And is that something that could be added on to the path rather than on our labs, because how many outpatient therapists want to use a pre-op, outpatient appointment towards their CAT?
Right, exactly. I would definitely agree with that, yes. A lot of research has shown different medical professionals administering the pain science, whether that's nurses, physicians, physical therapists. So yes, I think it is appropriate for all to be able to educate on that. Jeff?
Was there a reason you chose two separate surgeries? My experience is rotator cuff repair is much more painful post-operatively. I have two questions though.
Okay.
Post-operatively than slap. Any reason?
Originally, we were going to look just at rotator cuff repairs, but then we tried to make it a little more broad to see if it can be related to a larger case and even to make good comparisons between both patients. But yeah, I would say, in my experience as well, rotator cuff repairs more painful.
And then my second question is, in the education piece, just from a pre-op visit, do you educate them on opioid use post-operatively?
It's a good question. So this, I think I have a picture of it up.
And when I say that educating them, I'm using it.
Oh, that's not working. Anyways. So we did address medications, and we did not say, well, what we mentioned in the bottom is actually right there, here. Medications can help with pain and use it as your physician prescribes, and we will try, over the course of time, we'll try to wean off the medication. That's pretty much the education we gave for that. That's right there. Any other questions? Jesse?
You said you looked at active range of motion as well, right?
Yes.
Just out of curiosity, did you notice a difference or an increase, pre-education and post-education? Is there an increase at all in the range of motion?
We did not actually. In some, there was actually a decrease, and we didn't present the results there. In prior studies, it did show that, but none for the shoulder have been shown to improve range of motion, so this one did not. And Steve?
Since this was the same surgeon, did that surgeon notice any difference in opioid use in comparison to their other patients?
That would be a great question to follow up with, and I will definitely ask that and then be able to present that to you guys. But very important, especially if we were able to get the surgeon to realize that there was a difference, then the value of this would even skyrocket. Because not a lot of surgeons will prescribe physical therapy for a preoperative visit. Go ahead.
The term central sensitization, is that synonymous with McKenzie centralization syndrome?
No, it is not. No. This is more of something that's within the brain's perception of decreasing the inhibition or inhibiting the pain signals. Chuck.
So you focus mostly take on pre-op shoulder surgeries here for what you base your interventions on.
Yes.
What other populations that you think this would be very useful to use in terms of physical therapy, like examinations?
Yes, there is this background of this research of pain neuroscience education started more so with the chronic pain population. So chronic low back pain is something that it's been well researched with, that shows even systematic reviews showing that it is effective. So that population, as well as not just low back pain, but chronic musculoskeletal pain in general. Any other questions? All right, thank you.
All right, that concludes our research day. Thank you guys very much for coming. It's very appreciated. And thank you for all your questions.